them, and directly or indirectly. Directly means they will be from the respiratory or the pulmonology or the diagnostic workup, and indirectly means they might be related to the cardio renal system and pharmacology. So let's start with some of the basics. We know ventilation is delivery of the air to alveoli and back outside. So how do we assess the ventilation is via pulmonary function tests. In the pulmonary function test, very important pulmonary function test is called spirometry. Now this spirometry basically it involves the exhalation from a total lung capacity to the minimal residual volume that stays always inside the lungs. So the crux of the matter that you have to understand here is that spirometry starts with blowing into a gadget. So that means that it is basically starting from total lung capacity. Now, many times a question is asked in the exam that the which of the following is not correct about spirometry is so the fact that it is the fact which is not correct usually is that you start at vital capacity, or you start at tidal volume, or you start at inspiratory capacity. So these are all false statements. So basically one starts at total lung capacity, which includes vital capacity, which includes functional residual capacity, which includes the residual volume. So basically total lung this total lung capacity is basically a combination of two volumes. One one is vital capacity and the other is residual volume. So with spirometry, we get to know about some capacities and some volumes. So capacities are usually defined as abilities and volume is a noun. We know that. So they are the factual matters. Capacity can be increased or decreased, whereas volumes are static. This you have to understand that capacities can be increased or decreased. Volumes, the volumes that we get in spirometry are inspiratory reserve volume. Inspiratory reserve volume means, okay, we'll start with the tidal volume. So this is the tidal volume. That means the amount of breath, the volume of air which moves in and out during a normal breathing cycle. So if you inhale beyond what you can normally inhale is called the inspiratory reserve volume. And then you fall back on the tidal volume. The amount of air that you can push out from the lungs after you have done it normally as a tidal volume is called expiratory reserve volume. Now this is amounts defined with volumes. Okay. So whatever we are doing in the normal circumstances is the tidal volume. Whatever extra we breathe in is called inspiratory reserve volume. And whatever extra we exhale is known as expiratory reserve volume. Now, this amount of volume which never leaves the lungs is called residual volume. This never leaves. So that means if we are breathing normally at a tidal ventilation, that means at this point of time, the amount of expiratory reserve volume is also not leaving the lungs because it will leave if you would want to. And there is a volume which will not leave the lungs even if you would want to. So this combination of residual volume and expiratory reserve volume becomes the capacity. So this is called functional reserve capacity, and this is the most important capacity defined because you can increase or decrease and it helps you tide over the difficult circumstances like staying stopping your breath for some time, staying underwater for some time. It is the expiratory reserve volume that people tend to increase, leading to an increase in the functional residual capacity. At the same time, the volume of air that one can inhale over and above the tidal volume is called inspiratory capacity. Now, this inspiratory capacity is again an ability to increase the amount of air that enters into the lungs. So that means on an average, if I do not count the amount of volume that can never leave the lung, the person can play with his lungs within this field, which is known as vital capacity. Vital means life, capacity means circumstances leading to abilities. So, vital capacity means whatever situations may arise, you can increase your breathing, you can increase your volume inspired, and you can, in fact, increase the volume that you release as well. So, how does this clinically affect us? And clinically, the questions. So, the key measurements would be the first second forced expiratory volume. So, whatever air you expirate in the first volume, first second, is called FEV1. So, this is volume exhaled forcibly. Now, wherever forcibly comes, this becomes reserve. So, if you just look at it, inspiratory reserve volume and expiratory reserve volume. So, whatever you are forcing out of your system is taking away all the reserve of the lung. So, whatever you force out in 1 second is called FEV1. Forced vital capacity is that this is the tidal volume. You expel out the maximum amount of volume after a complete inhalation. So, this is known as forced vital capacity. Forced vital capacity is a very efficient determinant of patient's pulmonary reserve. Then, of course, is tidal volume, which is the inhaled and exhaled volume during normal breathing. Reserve volumes we have just discussed. These are the ones that can be forcibly inhaled or forcibly exhaled outside the normal tidal breath. Now, these flow rates, which are the expiratory flow rates, why? Because we actually blow into a device. So we blow into a device. So blowing is an expiratory phase. Blowing is expiration. So expiratory flow rates, if you plot it against lung volumes, this gives you flow volume curve. Now, this flow volume curve can tell you a lot about patient's condition, and in fact, you will get a lot of questions based on flow volume curve. So, let's first see which is the normal flow volume curve. So, when you see this curve, this is the normal flow volume curve. This is the flow per second, and this is the lung volumes. So when you plot the flow per second against lung volumes, we call it flow volume curves. Okay, you can see it here. So this is expiration. Now in this, expiration is plotted on the positive side and inspiration is plotted on the negative side. So if you just look at this, this is the expiration. You are actually blowing into the machine. So this is, and as you blow more, your volume also, the volume increases that you have blown, but the capacity continues to decrease. So the flow continues to decrease, and then it reaches a point where then inspiration starts. So this is the normal curve, expiratory, inspiratory curve. This is the normal curve. Now, if the volume of the lung remains the same and there is a small airway obstruction. So airway obstruction means one has problem of expiration. So COPD, asthma, bronchiectasis, they all deal with expiratory prolongation. That means if expiratory prolongation will occur, we will see a plateau somewhere here. So you actually see this position. So the expiration is slightly prolonged and has a flatter curve. The inspiration remains the same. Then comes COPD terminal, where patient exhales and again you see the plateau is so much that it literally becomes a flattened curve. Then, if there is a fixed large airway obstruction like in malignancy or an impacted foreign object, in these cases, what you see is beyond that volume, beyond that place, the lung will not be able to take more inspiration as well, more expiration as well. So, this is kind of a stunted normal graph. So, you just have stunted normal graph. This is fixed airway obstruction. Variable extrathoracic large airway obstruction means there is a problem at the level of vocal cords. So the patient tends to expirate immediately. The curve is sharp and then the inspiration is very poor. So you see a very flattened inspiratory curve. Now, if the lung volumes have decreased, like in restrictive lung disease, let us say the volume is this much. So the flows will still be maintained at the same level, but the volume will decrease. So this speaks the lung volume has decreased. The lung is keen to get emptied and the lung is resistant to be filled. So you see a quick expiration followed by a quick inspiration, a short inspiration. So this is ILD or pulmonary fibrosis, post COVID lung syndrome. These are all same. So if you see a plateau on the inspiratory curve, that is below the line, that is extrathoracic large airway obstruction. And if you see plateau on the expiratory curve, you basically it is intrathoracic large airway obstruction. So if the plateau is here, basically these are different situations of large airway obstruction, which is intrathoracic. So this is an MCQ. Very important that inspiratory curve plateau means extrathoracic large airway obstruction because that is where stridor occurs. Plateau of expiratory. Now these plateaus they make sound. Okay, plateau of inspiratory curve creates stridor. Plateau of expiratory curve creates wheeze, and we all know wheeze is an expiratory sound, and stridor is an inspiratory sound. Like any test, like any test, there are problems with spirometry as well. So, what are those problems? It cannot measure the residual volume, so it is only calculated. The residual volume remains inside the lung. So, what you can do is like you can measure the body weight of a person, tell him to breathe out the maximum, and then again measure the volume for the body weight. This is called plethysmography, that you put the person into water and then the body floats. Then you calculate the amount of air in the lung which is left. So that tells you the residual volume. These are called static testing of the lung. So residual volume cannot be measured by conventional spirometry. Any capacities which involve residual volume, like functional residual capacity, like total lung capacity, they cannot be measured with spirometry. They are all measured by either inert gas dilution like helium or plethysmography of the body. How does helium help? So you measure the amount of helium, you let it go in. Let us say you send in 100 particles, 60 come out. That means 40 have left inside. So this means that you at least got to know that this is the indirect measure of residual volume of the lung. Okay. Now, there is another test called peak expiratory flow, which is very important for bronchial asthma patients. In UK, they can actually give the PEF meter, peak expiratory flow meter, to the patient. Now, this expiratory flow is measured by a maximal forced expiration through a peak flow meter. That means you're literally testing FCV1. So in the first Second, whatever forced air you are expelling out of your lungs is being recorded in this situation by a gadget. So this correlates very well with FEV1. It is used in an estimate of airway caliber. Routinely, it is measured in asthmatics to monitor the response to therapy and disease control. In COPD, in variable situations, it can underestimate the disease severity of COPD. So let us see in abnormal ventilatory function, the in obstructive pattern, what you see is that there the ratio of FEV to FVC is very important. So we consider it that it should be zero point 0.7 to zero point 0.8 under normal circumstances. So if FEV1 by FVC ratio is less than zero point 0.7, it means that the person is suffering from obstructive pulmonary disease. Severity of obstruction can be determined at the level of reduction of FEV1. We'll come to that. In restrictive disease, the FEV1 to FVC ratio is normal. Why? Because there is no problem with the airway. It is only the lung volume that has shortened. So the amount of air pushed out and the amount of air that moves in as vital capacity remains proportionally same. All right. So if you just look at this table, it is very important and it will help you. You can take a snapshot of this table. You can, in fact, define the pattern of disease by looking at these values. Most importantly, FEV by FVC. So in obstructive disease, the ratio is decreased, that is less than 0.7, whereas in restrictive disease, if it is pulmonary parenchymal, it is either normal or it is increased. In extrapulmonary neuromuscular disorder, it can be variable. In chest wall deformity like kyphoscoliosis, in all these conditions, you will have a decreased total lung capacity. You will have uh, a normal or a variable FEV to FVC ratio. But for a person who has myasthenia gravis, again, you will have such a picture because as such the airway is intact. So ratio of FEV1 to FVC is less than 0.7 only in case if the airway